Who is the right candidate for robotic surgery after a prostate cancer diagnosis? What is surgical margins? Anyone who's been diagnosed with prostate cancer has seen the biopsy report, or they've had their urologist tell them, you have positive surgical margins. What does that mean? And what about the hood technique as it relates to robotic surgery, as it relates to sustaining and maintaining urinary continence after robotic surgery? Today, my conversation is with Dr. Ash Tewari. It is such a pleasure to have this conversation with Dr. Tewari, who is a renowned urologist, prostate cancer expert, and global leader in the field of robotic surgery for prostate cancer. If you're watching the video, you will notice that around minute 25, there's a static image there because we did have a technological a little issue there. So it would go from a live conversation between myself and Dr. Tewari, and then the conversation continues live, but then there's a static picture of Dr. Tewari there. That is if you're watching the video on YouTube. Please enjoy this amazing conversation on robotic surgery for prostate cancer with Dr. Ash Tewari. Let's welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my goal and intention to help you optimize your prostate health and how to live better with age. Today, I have the great pleasure of talking to my friend. He's a senior. I call him Dr. Tewari because I have a hard time with my senior people in urology that I talk to saying their first name, but we become such good friends. Ash, thank you so much for being on. It's a late day. I know how your days work. I know they're very early, so I really appreciate you being on.
Gio, you are here too at this late hour, so both of us have the similar passion for doing something for the right reason. You mentioned
Absolutely.
you mentioned that we should dwell upon a little bit of an history of how the robotics came along.
Yeah, we talked a little bit before I hit record, and so as a naturopathic doctor who does holistic urology, I've been doing it now since around 2003. And I remember, robotic surgery becoming very popular at that time. And the names that came up oftentimes, there were a few. Ash Tewari was one of them back then. So I think you're part of the history because you learned from Dr. Menon. So go ahead and let's dive into a little bit of that history. When did it start? When did you start? I think when I started learning about robotic and learning about you, and you already had like hundreds of cases in all, early 2000s. So take us back and let us know, when did it start? How did it start? How was it brought to the US? And you're part of that history. Take it away.
So, Gio, the year was around 1998-ish,
Mm-hmm.
and Dr. Menon was my chair at that time. I had moved from Florida to Michigan, and
Mm-hmm.
he was exploring options about how else can we treat prostate cancer other than radical prostatectomy, which he was very good at it. He was trained by Patrick Walsh, and he himself was a good surgeon doing an open radical prostatectomy. But there was always a desire that can you do it better? And that better was, can we see better? Can we bleed less? Can we make a smaller cut? And can we be more consistent in saving nerves and protecting the continence mechanism? These were the main drivers, and exploration was going on. He and I looked at some of the surgeries which were happening in actually Europe, and Dr. Menon was futuristic enough to look for some surgeons who were doing a straight names. They came up.
Mm-hmm.
He invited them, and my role was to kind of receive them, and sometimes they stayed with me at my apartment,
Mm-hmm.
and sometimes within his apartment, and I used to pick them up at the airport and bring them home. And we started doing a straight laparoscopic prostatectomy in early, before 2020, before
Were
2000.
you a fellow or faculty or at that
So
time?
I had a different journey. I was an already trained surgeon, general surgeon, and an urologist from India who had
Mm-hmm.
gone to UK to do a fellowship in kidney transplants and pancreatic transplants.
Mm-hmm.
Came to UCSF to do a fellowship in prostate and prostate cancer. Came to Florida to continue on that journey, and then finally decided to do the boards again, third time. And I was doing my board certification in Michigan at that time. I happened to have a joint appointment with an Josephine Ford Cancer Center, which was there in Michigan. So I had some grants. I used to run my own lab, and in the daytime, I was a trainee, and but a trainee who had pretty experienced surgical background. So,
Mm.
so Dr. Menon and I used to talk a lot. I mean, I think we used to have a walks every weekend. We used to move around and look at different options, and that's how it started. About can we do something in laparoscopic prostatectomy? So we started doing that in Michigan,
Mm.
and I learned with Dr. Menon, and I learned with Bertrand Guiano, I learned with Valencian, and we realized that
French surgeons?
French surgeons, and they were from Paris.
Mm-hmm.
So I then decided to bunch up or kind of pool all my vacations, which I had not taken in a couple of years, and pooled my vacations and go to Paris for about a few weeks. And then started doing it there, got a little comfortable about what we were doing with the straight laparoscopy. Right at that time, right at that time, there was some new technology was being talked about it, and that was known as a robotic surgery. And that robot was a master slave system, which was built by Department of Defense and DARPA's and NASA's to kind of take care of remote surgery. The
Mm.
first goal, I think, was that can you treat an appendicitis in an astronaut when they are in space?
Mm.
So that was the goal. And if we can do an appendectomy for someone who is in space, because no antibiotics or no conservative treatment will treat it, you need to do a surgery. And then if you can train the rest of the astronauts into connecting the robot, then someone sitting in the Earth can possibly finish that operation. That was the goal.
Mm.
But that robot became a very useful tool, not just for this kind of an venture, but also for the battlefield. If there was a gunshot wound to a major vascular artery, and if something needed to be done, and there was a trained surgeon remotely, that surgeon can connect through the robot and take care of it.
Right.
So that
Mm-hmm.
was the theme, and this robot initially was built to treat cardiac issues and heart surgeries. But
Mm.
somehow it didn't catch that much of an excitement in that field, and there are only two organs in the body which look like heart. One is heart, another is prostate.
Oh, interesting. Was Da Vinci the company already at that time?
So Da Vinci was the intuitive company was there, and
Mm-hmm.
so the CEO of Da Vinci came and met with Dr. Menon, and I happened to be there in all the meetings and in the dinners and everything. And we also wrote some thought process discussions as to what this robot can do. There was another parallel robot also, which was not as sophisticated as the Da Vinci robot. So we tried all those things, and then we launched on, okay, let's try doing a robotic prostatectomy. And basically, year must have been 1999 or 2000, and where we
Mm.
started doing it. French surgeons used to come and stay with us. And as you can appreciate, robot is one person is on the console and one person is always on the bedside
Mm-hmm.
to help in making this thing happen. And initially, I got very good in actually bedside because someone had to connect the robot, someone had to open the field, someone had to safely get in and get out of the abdomen. And we took some time in the beginning in finishing these operations, and maybe one a day, one a day, one a day. And then the time came, we started doing two a day. And then by the time I left Michigan in 2004, we were doing four to six a day.
Mm.
And I had initial 1,000 cases. I was part of each one of them, and at that time, in 2004, I had to make a decision that what do I do? And I was lucky enough that Derekat Vaughan, who was the professor at Cornell, was a
Hmm.
visiting professor in Henry Ford Hospital. And he saw my work and he saw me operate, and he liked what he saw. And then next thing was that I came to New York, and
In
it's 2000.
2004, how many have you done already? How many robotic prostatectomies you think you've
I
done
think
by that time?
between my training time and everything in Henry Ford, I was close to 1,000.
That's what I correct. That's exactly what I sort of heard as a
But
non-surgeon.
they were my training cases. They were my training cases,
Hmm.
and then since then, every year I've been doing about 500 of these, and I've been doing it for now since 2004 till now. You can calculate. It's been long number. But
Yeah.
very early on, I got interested in not just being able to do it robotically. I was very interested in the anatomy and what is different in terms of erectile function and the continence and all those things. And I just came back 2 days ago from Japan, giving an 1 hour talk on each one of these topics, one on the hood and one on the nerve sparing. And basically, the vision helped us, lower bleeding helped us, and patients started doing better. And that's been the journey. And every 1,000 cases, you have some refinements, and every time you learn something new, you incorporate that into your practice. I became a very strong proponent of looking at anatomy in a different way. Mainly,
Mm.
I was big influence about that the nerves are not that simple that you can call them bundle. They are
Hmm.
more like in hammock, and there are multi nerves there. And in
Mm.
order to get a better response, you have to save the most of the nerves, not just the one in right and left discussion. So that hammock concept came. We started realizing that there are different layer within the layer around the prostate, and the nerves are concealed within those layers. And in order for us to tailor the surgery for an individual patient, we have to kind of appreciate what's the likelihood that the cancer is trying to escape outside. So we did a lot of research on risk stratification and the grades of nerve sparing. Then came a discussion about simultaneously, I got very invested in MRIs. So early 2006 and 7, not MRI was not that common, but I somehow felt that the next big thing which will happen in prostate will be an MRI, and that MRI helped not only in making a better decision about the biopsy, it helped me in fine tune the surgeries so that we can get a negative margin and yet save the nerves as many nerves they are savable. We did a lot of research on different aspects of nerve sparing and the continence and all those things. So that has been the journey. And now I'm lucky enough that guess what? Dr. Menon decided to come to New York, and he is
That's what I saw
right
that.
across my office, is still mentoring me. So when you don't finish the job first time, he's to finish the job now. And
So he does it. So the sometimes mentors are like a parent, and they teach you the way. And then sometimes, with my parents and with parents that they get as they get older, then sort of you become their parent in terms of helping them along. Has the roles changed? Are you more?
no, not,
are
not,
you are you
he's,
his mentor at this point after all your
not,
experience?
he's still, and but he's so subtle and so kind, and
Yeah, he is. He's a
that
great person.
he's
He was at NYU for a little bit of time when I first came. I didn't have any time to interact with him, so I look forward to interacting with him soon because he's a legend.
he's a legend, and then he's so kind, and then see he even if he has to suggest something, he will do it very softly, and so I'm lucky. I'm still getting the benefit of him guiding me through.
You mentioned a little bit earlier that you try to improve your technique to have so that there could be less positive surgical margins. I'm going to assume that much of my listeners don't know exactly what that means. I'm going to explain it, and then please correct me if I just get it wrong. Surgical margins, once they remove the prostate, if you look like, for example, an orange, there's a peel in the orange. And then once they remove the whole prostate, which in this analogy is the orange in the inside and the peel, sometimes the pathologist puts a little ink on the outside, and if that ink pops out on the peel, let's say on the outside of the prostate, that means there's a little bit of cancer outside of the capsule. Did I get that right, first of all?
I think you did. In a simplistic way, margin positive is one thing which is not positive.
Mm-hmm.
Basically, it is a surrogate for saying that there may be some cancer left behind. And then
Mm-hmm.
big, maybe. Not always.
Not
That
always.
end of it, that may be the end of it, what you are seeing at the edge. But having a negative margin is very priceless, and you have to do your best in getting a negative margin. But this is one operation where you don't have much of an leeway. The tissue is within few millimeters of each other, and on one side is a cancer cell trying to lurk outside the capsule. On the other, there are muscles which are wrapping up the continence mechanism, and the nerves are going through and through, almost hugging and touching the edge of the capsule.
Mm.
So, in order to get one right, sometimes you have to compromise the other right. So, what we call there is a competing risk of damage to this versus that, and to find a fine balance in which all three things are done, we call it trifecta. Meaning, you got a negative margin, you save the nerves, and the patient is continent. All three combined, it's a very fine balance. And that's where a lot of pre planning goes, a lot of decision making grows. And I personally think that finding a cancer early is in one of the most important aspects in this journey. That if the cancer is already trying to escape outside, it becomes more difficult to save the nerves. While if it is within the capsule, most of us can get the whole cancer out, yet save the nerves.
Mm. And so once you're in there, again, so once you're in there, you're. By the way, thank you for sharing much of the history there. It's remarkable. I'm a little bit of a history buff, so I really appreciate some of those details I didn't know exactly. So thank you so much. So you found, and please, so as we go along in this conversation, Ash, you feel free. You've written also, by the way, it's not only that you're a top surgeon, you've written hundreds of papers. And I've saw you've written, even up to recently, you have your first author many papers. So feel free to either cite or highlight any research. But I also care about your experience as well, not just the research. I think sometimes we get so caught up in the research, and I think that your experience as someone who's seen, I lost the math there, but it looks like it's almost like 10,000 procedures in prostate cancer. That matters quite a bit. So please share both with us as much as possible. Um, when there's a surgical margin that is, when there's positive surgical margins, so remove the prostate, pathologist says positive surgical margins. Does that mean that the surgeon was unable to kind of get it all potentially? There's a minor or some sort of increase of a recurrence. In other words, is it a surgical issue? Period. End of story. Or is there more to positive surgical margins?
So, positive surgical margin is a fine balance between how much we are aware of that patient's cancer. So
Mm,
what happens? You mentioned very well that there is an orange and an peel,
mm-hmm,
and think about prostate as a pulp of the orange and peel as the capsule.
mm-hmm,
But now imagine this orange wrapped into the holiday gift boxes, and this orange is coming out in multiple layers of very flimsy paper around it, so that you have to unopen those paper covering before you get to see the peel.
mm-hmm,
So there are two situations. One situation in which, while you were opening, you just kind of cut through the peel and you ended up into the pulp. And it can happen because there is an inflammation. It can happen because the capsule or the peel is thinned out. It can happen because that is a weak part of the body, or it can happen just because there was not a good vision. That is one kind of an positive margin, that your cut area ended up within the prostate and that it touched some of the cancer cells. Second is, you are peeling out those papers outside the orange, and the pulp itself was leaking outside the peel. What we call extracapsular extension, what we call that there is an extra capsular, extra prostatic tissue the cancer is trying to invade through.
Mm-hmm.
Now you can take the whole orange out with the peels on it. That's fine, but you are sacrificing the nerve. So if you find a cancer touching when the cancer has already invaded through the capsule or the peel, then it's a different kind of a positive margin. These are two different positive. One is known as intraprostatic positive margin, other is known as extraprostatic positive margin. And then the other part to look at it is which part of the prostate we are looking at it. It's at the urethra, it's at the bladder side, it's at the front, it's in the back, it's at the near the nerves, it's at the apex. Then you look at what extent of area is showing a positive margin. Anything less than 1 millimeter, 2 millimeter, 3 millimeter may mean something different than in 7 millimeter of cancer touching the edge.
Mm-hmm.
Then you look at it, what the cancer itself in a prostate is not the same in the whole prostate, meaning in the same patient, one part of the cancer may be Gleason 6, other may be Gleason 7, and another part may be Gleason 8.
Mm.
So if the Gleason 6 is touching the edge, it may mean something different than Gleason 8 is touching the edge.
Mm.
Meaning the bad guys were the one which were at the positive margin. So all that combined, interpreting the pathology in the positive margin is an art and a nuance. Not every time when you get a positive margin, there will be a PSA recurrence. I would say maybe 40-50% of the time that happens. But that's where you factor in as to what needs to be done. So, one of the ways of reducing the positive margin is understanding that patient's anatomy better than anything else. Understanding left is different than right, front is different than back, base is different than apex, meaning you cannot have the same strategy of when cutting in a particular plane everywhere. You have to modify it. And how do you modify it? Because till you have a Google map of what is happening in that patient's left side versus right side, you won't be able to do that. So we maximize it by doing a special scan, by doing exams, by doing MRIs. And we have a nomogram that we plug in everything into one nomogram, and that churns out what's the likelihood of having a cancer extracapsular extension on the left side, right side, front, back, and all those things.
Do you have your own nomogram that's different from the Sloan Kettering one that we find on the website? You have your own?
Yeah, because most of the nomograms just say that whether there will be an extracapsular extension or not. This nomogram tells you whether it will be on the right side or the left side.
Oh, okay. And that's your own. The rest of us don't have access to it. It's not
I
like you put in
think
some
that
numbers.
published very well. It's been quoted very well. I think it should be available to anyone, and it's nothing proprietary. I mean, it is, and we have made it out of two different methods. One is using an ultrasound, and other is using an MRI. So
Gotcha.
all
Okay.
combined, when I am driving and I have to go to Jersey, I know whether I'm going to take a Harlem River or I go to 70 through across the street and then take the Henry Hudson Parkway,
Mm-hmm.
because I know already that there is a jam on one of the roads. So
Mm-hmm.
you tailor the surgery based on a particular patient's anatomy. Then I already, before doing the surgery, I already know that they have a median lobe or not, and they have a 40-gram prostate or 17-gram prostate or 170-gram prostate. All that will have an impact as to what's going to happen at the time of surgery. One of the challenges which as a surgeon we have is most of the time we do what we think is the best at the time of surgery, finish the job. 7 days later, we get to know whether or not there was a positive margin. That was a challenge which I tried to address in 2014 with the help of some of the doctors who came from Hamburg. It's
Mm.
known as Martini Clinic, and Alex Hess and some other doctors had initiated a program that used to be called as NeuroSafe. So I was pretty close to them. I called them. I said, Alex, you should come here. They came with their team. They stayed here for about a week, and
Mm.
we started having the NeuroSafe right in my program. What it means, I finished the surgery. While I'm doing the anastomosis, while I'm doing the lymph node, pathologist is working in parallel on the pathology right then and there. And within 30 to 45 minutes, I get to know that on the right side there is a positive margin or there is no positive margin. Because if there is a positive margin on the right side, I can still excise a little extra tissue on the same side because
While
it's
the
an
patient is still under anesthesia, the patient, you still have the
yeah,
robotic arms in the patient.
yeah, I'm working on it, maybe 10 minutes extra waiting. It's an actionable information. So I can excise more right then and there. And then we looked at what is the concordance between this report and the 7 days later report. And they will give the 7 day later report too. 95% concordant. So that was a major gift which I got and had nothing to do with me. Only thing was that the pathology department was very collaborative and they went far ahead and they had to invest a lot to make it happen. But we initiated that UNeuroSafe and that was not generated by our department. It was a gift I got from Germany. So that
I visited. I visited. So they invited me about 7 years ago to the Martinique clinic to give a talk on lifestyle and natural methods to prostate cancer. I was so impressed with the group there. Thorsten Schlom, who's no longer, he's in Berlin now. It was the one that invited me. Great group.
Geo, that is exactly how it happened. They had invited me to do a surgery there. I did this surgery, and while I'm doing this surgery, their pathologist came to the operating room and they started coloring it with the yellow and the blue and green. And I said, "What are you doing?" He said, "No, I'll give you the pathology right then and there." And
Hmm.
so I did the surgeries for demonstration there. Then I said, "Okay, now it's time for you to pay back. Come on over." And then they did it. And they were the
Is that
best.
standard how they do it? How they do their robotic surgery there? Is that what they do currently?
At initially, Martini Clinic was more of an open, but now it is 90% is
Ro-
robot.
Robotic, and they have a pathologist there
Yeah, yeah.
to. That's how they do it. So then, have you been able to apply that in your
For
clinic?
last multiple thousands of patients, that's what we have done.
Wow. Okay. And what do you call that approach? What is the name for
I
that
think,
approach?
out of the respect to them, it's a neurosafe.
Neurosafe.
Neurosafe. Thing is that if you have a second chance of correcting your actions, you save more nerves.
Right. 1, 2. Oh, okay. Sorry, I thought I lost you there for a second.
No, no.
We'll edit that. 2558. 1, 2, 3. So neurosafe. That is that is unique. Is there, so before we go into the hood technique, which is another approach that I think you have, I had Keith Kowalczyk from Georgetown on the podcast who talked about his Resnick technique, I think he calls it. So the hood technique is another approach. Before we go there, is there anything else that you do that's unique with your surgery?
I don't think anything is unique. It's just the experience and basically the grades of nerve sparing is in concept, which gives me a little bit extra understanding how delicately I try to manage the nerves and what we call athermal traction-free nerve sparing. Of late, I have developed something known as a hydrodissection, in which I use water jet to dissect out the nerves. That's another issue which we are working on it, and they are neat techniques for us to how to achieve a delicate dissection without compromising on the continence or the posterior margins.
Speaking of nerve techniques, Ash, you're in there, the arms are in there, you're looking at inside the body, and you're seeing that near the nerves there's potential cancer. So my first question, again, almost I think everybody listening, if not or most everyone listening, are not surgeons. So we're trying to draw an image of how you do what the art that you do. You're in there near the nerves, you see cancer. First of all, is cancer obvious from normal tissue when you're in there? And then the second question is, sometimes you have to remove those nerves because there's just too much cancer either around those nerves or in those nerves. Is that typically how it works? So you make a decision while you're there. So first question, does cancer cells, once you're in there, look very similar, very different to normal cells? And how do you determine when do you have to take out the nerves because there's just too much cancer around it?
So a lot of it depends on the pre-planning. We shouldn't be over-promising nerve sparing, and if someone has a Gleason 9 T3V cancer, that's not something which is a good candidate for nerve sparing. Second thing is that with experience, you start seeing things which doesn't look right. You can never be sure without the microscope that it is in cancer invading into the nerve or not, but you know that the planes are not looking right. And before you have to have your priority right. Priority is cancer is the goal number one, cancer is the goal number two, cancer is the goal number three, then comes the continence, then comes the sexual function. But in a Gleason 7, I can have nerves as a more important goal in my mind because the likelihood of an ultimate mortality and ultimate recurrence and ultimate bony metastasis is lower. But if it's a Gleason 9 and 10, that's a different discussion. So we are writing a paper which is the title is Nerves, Foes or Friends, a deep analysis. So sometimes in an aggressive cancer, nerves may choose to kind of interact with the tumor microenvironment and supply it with what we call an angiometabolic switch. And that itself can make the cancer more aggressive. So it's a fine balance between nerves on which side, and the nerves, whether they are cholinergic or whether they are sympathetic nerves, they may have a different interaction with the cancer cells. So you are right. Experience helps me up to a point. Pathology gives me the second confirmation, but pre-planning and understanding as to what is important for that patient is in key in the whole journey.
So it's not only that you're in there and you're saying, well, there seems to be cancer near the nerves. You're going by the Gleason score as well from the biopsy.
From the Gleason score, from the biopsy, from the MRI information about the pyrite, for MRI information of extracapsular extension, whether there is a seminal vesicle involvement, whether there is an abutment, whether there is a broad capsular capsule, whether it's in the front of the prostate at the apex, all those things combined, you kind of, and it's an anticipation also. You start seeing things differently if you're anticipating them to be wrong or abnormal and then right side versus the left side.
That's great. Thank you for that. Tell us about hood technique, which I've read about some papers that you've written. What's in layman's terms? what is the approach, and how is it different from anyone else who would perform this procedure?
I think a lot of people are doing the hood technique, so it's not that only I do it. I just happen to kind of talk a little bit more about it, and I wrote the papers on that. So basically, the theme is in prostate cancer surgery, you cannot focus on one thing. I can make most patients continent if I don't have a good surgical margin. I can make most patients negative margin if I don't worry about the sexual function. So it's the fine balance discussion. So the approach which gets you to have the fine balance between the optimal cancer control, optimal nerve sparing, and still the continence, that is the balance, and that's where the exposure of the tissue comes. So surgeons do well if they see things in clarity. That's what the theme is. So I think I give the credit of the hood technique to Dr. Bucciardi, who is an Italian surgeon who came up with an approach also known as ridge sparing approach. Ridge sparing approach is that you go behind in the pouch of Douglas, you take the prostate out, and you work in a little narrow space, and if you take the catheter out, within few days the patients become continent. I mean, I think that helps. But that came at a cost of possibly working in a very narrow space, never getting to see the ureteric orifices, having an issue with the median lobe, anastomosis being difficult, working within very precise, very narrow space to the nerve sparing and all those things was an issue, and maybe having a little bit extra positive margins. So I wanted to get the same concept of early continence without compromising these key goals. So I devised this approach in which I saved the whole entire part of the bladder to prostate, and that area looks like a hood, and underneath there are fibrous tissue, there are veins, there are muscle fibers, and it kind of holds the bladder and the anastomosis together. So at 1 month, when we look at it, the continence is amazing, but you don't compromise on the margins, you don't compromise on the nerve sparing. So you kind of find an perfect balance of these three things without compromising on the surgeon's approach as to how they do the surgery. And since the structure which I am saving looks like a hood in front of the anastomosis, we call it hood technique. And basically, with the earlier continence, it's very versatile, and you don't compromise on the other two key goals, that is the cancer being out and the nerves being saved if we can.
I've noticed, I have gotten the pleasure and the privilege of seeing now thousands of patients as well after their prostatectomy for wellness visits to reduce the risk of their recurrence through lifestyle measures and things that I do. I find that many surgeons are just doing a phenomenal job with prostatectomies these days. I find that the incontinence rate is relatively low. I'm talking a little bit generally. Certainly in New York, there are just so many great surgeons and well experienced. But I find that many are doing such a good job in with their patients and where they are able to recover their continence pretty quickly. What's the learning curve these days? So if I'm a new resident, I just started as a resident. What do you think is the learning curve before someone becomes proficient in robotic prostatectomy?
I think I'm the wrong guy to answer that question. I'm still working on the process, but you need to tweak it. I mean, I think you need to reevaluate your own results. You need to focus on what could have been done different. And really, in this upcoming symposium, which I'm running here in December 7th, 8th, or 9th, or something, we are going to show many videos of the very good nerve sparing and very good continence thing. And then we have the outcomes on those patients. And then we will have the team identify what are the factors. Why do you think he's doing well? What happened right? What could have been done different? So self-evaluation, learning curve is in very artificial number. You need to feel comfortable. And I leave it to an individual to figure it out what that number is. Some people are rapid learners.
So this doesn't get old for you. You've done. I calculated a raw number. I don't know, 8, 9,000, 10,000. This is still a. You're still learning and perfecting the art.
With the Japanese group, trying to tweak a little bit here, tweak a little bit there. I mean, that's what I do.
That is great, Ash. I have always admired that part of you. I know that's I have so many of your patients who see me for wellness, and God, they speak incredibly highly of you and your procedure and how you do things. Ash, you wrote a paper, a review. So I've said this before, and the listener is going to say, wow, Dr. Gio says this all the time, but it brings context. When I see patients that have had a history of prostate cancer or have prostate cancer, whether it is that they're on active surveillance, and then I put them on aggressive lifestyle interventions, and then they do their second or third second biopsy, and then it's like negative for cancer. Well, and then people, Gio, how do you treat prostate cancer? We have this patient that their second biopsy, no cancer. And the PSA's dropped, and they did your protocol. Well, I don't know that I treat prostate cancer. I'm treating the microenvironment. So I'm a microenvironment prostate cancer doctor, right? After, whether it's active surveillance or after surgery, we want to reduce the risk of a recurrence. I see that oftentimes. Sometimes they come to me with a recurrence, with a PSA that's rising after, let's say, surgery. And then they find that their PSA stabilizes pretty nicely for a long time once we do some protocols. Wow, so how do you do this microenvironment thing? Well, there's certain things I'm trying to do, but certainly I'm trying to reduce chronic inflammation. You wrote a paper, review paper, maybe in 2020,
14 or 15.
2014, 15. A review, I mean, a great paper on inflammation. Here, Ash Tewari, you would think, oh, no, he just stays with 2014, 15. A review, I mean, a great paper on inflammation. Here, Ash Tewari, you would think, oh, no, he just stays with, all his papers are around surgery and things like that. You wrote a wonderful paper on the inflammatory effects and that it contributes likely to progression of prostate cancer. That is one of the things that I try to address with some of the things I do. Talk a little bit about inflammation. Why did you choose to write that paper? And what is your perspective on inflammation and prostate cancer?
I believe that inflammation can be friend or an enemy. Inflammation done in a controlled manner can help in the healing. It brings in the right kind of cells, the neutrophils, the macrophages. But If inflammation persists, then it becomes a chronic problem, and there is a pathway known as NF-kappa B pathway, which gets involved. There are a lot of cytokines and chemokines which get released, and cancer cells can hijack these very powerful tools, which are normally used for controlling in bacteria, but it gets used by the cancer cells, hacked against the body's own defense mechanism. So it makes the rest of the immune system a little bit more immuno incompetent. It opens up through the metalloporphyrins and other chemicals, breaks away the some of the stroma around, and cancer gets an access to the nerves and the and blood vessels, and that's when it becomes invasive. So inflammation, uncontrolled, lingering for a longer period of time, is not a good thing. And inflammation is a known feature of a metabolic syndrome and obesity and all those things. So I personally feel that managing inflammation is an important part of doctor's journey. I'm not just a surgeon, I'm a prostate cancer doctor, and one which way I can reduce the load. And that's the reason when I put a patient on an active surveillance, I say, we do the surveillance, you do the activity. And activity is about the food and exercise and eating right and all those things. And same thing happens. I mean, I met someone today, who mentioned that I made him lose 75 pounds. And so I motivate them. I will do push ups for them in the office to celebrate the number of pounds, meaning I become involved with them. And I think losing weight and managing the body composition and inflammation and obesity are tied together.
I've seen that, by the way. Yes, I've seen that. Yes,
We have
I've
to
seen that.
make sure that reduces the recurrence, at least in my mind, gets more patients continuing on an active surveillance, and if anything, that reduces the DVT and all the complications of surgery if you have a more managed uninflamed. By the way, I wrote a paper, another one 2 years ago, two of them. One was about diverticulitis and Crohn's disease, and if in the pelvis that can make a prostate cancer more aggressive. So pelvic inflammatory disease may be a trigger for making cancer more aggressive. And then, of course, I wrote something about the COVID can make the prostate cancer more aggressive, and we may be seeing it right now.
That's right. That's right. I think we are actually, and that's very. I have not seen that paper. I'm going to pull it up and put it in the show notes as well. Ash, you are a holistic practitioner in every way. I mean, every time we see each other, we talk about different lifestyle measures. You yourself, you may still have a chin-up bar in your by your office where I've seen you do chin-ups, jump rope. I mean, you're a very active person. And before we started recording, I mean, you were telling me about, you're still playing cricket. Where does this come from? I mean, like, who are you? I had a Jay Shaw on, and we were talking about how unhealthy most doctors are, and the reason for that, and burnout, and things like that. You are the antithesis of that. What's going on? Why do you do what you do? I mean, and what is it? What's your program? What's your health regimen like?
First of all, we just do the best we can with the tools we have. And I have lost some very important people in my life because of avoidable health issues, which include my dad and my sister.
Sorry to hear that.
I love doing what I do, and I do mean that there is an investment involved into it, and that investment, if I have to do what I love doing it, I have to invest into my own well-being. And most of the time, if someone meets me in the morning and says, Ash, how are you? My first word really automatically comes, I'm happy. And there are now 5, 10 people who just poke me to ask me, Ash, how are you? I'm happy. And then they will smile and they will go on. So I believe that it's been a very rewarding journey for me, and a lot of friends I made, my family support. I mean, I've been very lucky with the family. But investment in your health is to be done by you. The toughest part was my undoing some of my diet, which is as in I can eat wrong. So, but I have cut it down for last 10, 15 years, I think, before I eat. So otherwise, that was an unhealthy thing. So having a relationship with the food is very important. Second, being a vegetarian and still getting the proteins and without getting the too much of carb is the balance. So I had to relearn all that.
Mhm.
I exercise about 4 times a week. I do invest at least an hour, and if I will get a chance, I will go out and I walk. I don't do too many parties. I don't do attend too many events just because I think the time. So if I have to summarize, I think about sleeping. I sleep well.
You do.
I sleep enough when I have to. So I kind of understand the value of sleep. I understand value of food the way it should be part. And we are athletes. I mean, as a surgeon, I am in pro athlete, so I have to manage my body according to that because I have to perform, and then I do about every day 3 surgeries, 3, 4 surgeries, a lot of patients. But I'm happy. And then the other part I think is I've got a really lovely team around, friends and employees and team members. They really care about what they are doing, and the atmosphere is of we work hard but we play
Love
hard.
it.
So
I love it.
I love at least watching cricket, but sometimes playing badminton and cricket if I can.
I love what you said. I love what you said. I always say, you know, life is a sport, so you want to train for life. You said, I'm a professional athlete. I do 3, 4 surgeries. And so that's a great way. And you got to prepare like an athlete. You have to be like LeBron James or, prepare and take care of your body so you can perform well in life and in your work.
I don't let any unnecessary thoughts come to me in the morning time. We don't talk about anxiety provoking.
I know that you and Deepak Chopra are friends. I told you before we started recording 25 years ago. I think a big part of what I do with holistic medicine, I learned Ayurveda, was because of Deepak Chopra. And I met him once a long time ago in a book signing. 7 Spiritual Laws of Success, Quantum Healing, all these great books. Has that influenced you, whether it's Deepak's work or something along those lines, to take such good care of yourself and look at things the way you do?
I think Deepak definitely is a great influence. He's a personal friend. But having a journey of life, and in my own life, I mean, I think late father, my mom, my wife, I mean, I think we are balanced and you learn, you reflect. Only thing is, I'm a 1% guy. I want to be 1% better next day, not 20%. And as long as then I'm consistent, things happen and you reflect, you analyze, you change, you tweak. You're never perfect. You and one other thing which I will always say that I've been on the wrong side of a discussion many times, but I know I will flip and go to the right side.
Ash, this has been great. I've learned, learned more about you during this conversation, all the history, the great work that you do that I was already familiar with, but some of those details, but how you function as a person, as a man, as a chairman of a major department in New York City. It's really remarkable to see all those different elements of who you are and how you do what you do. And I've always admired that.
Gio, thanks a lot for the kind words. There are always thorns around the roses, so life is a balance of both. So you have to learn it.
And lastly, I'll say, great person, great surgeon, but man, what a photographer. On your Facebook page, those that guys, you want to follow Dr. Ash Tewari on Facebook. Great photography that he has out there. Great photos. So that's just one extra great thing that you do. So thank you for that.
Gio, by the way, for my upcoming symposium, you obviously
I have a lot of followers here, Ash.
they can come.
And great. Tell us about your symposium.
Symposium is a 3-day event. First 2 days is about prostate cancer, everything from genomics to racial disparity to continence to sexual function to the PSMA scans and all those things.
Excellent. What are the dates? December 7th to the 9th, maybe. I appreciate you, brother. I really do. Thank you very much, everyone, for listening. This is a great conversation with Dr. Ash Tewari, Chairman of Department of Urology at Mount Sinai in New York. Ash, have a great evening. Thanks again, brother. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com Gio Espinoza, ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.